few words?
Hello.
Yeah.
What is your name?
My name is Sophie. It's nice to meet you. Okay. That should be fine.
Hello, everybody. I'm just being asked to ask you to take your seats. because in a moment we are going to begin. We're going to begin very punctually too with our keynote speakers, so please do take your seats. Thank you.
Now, dear Secretary Azar, dear Secretary General, dear Chairperson of the World Medical Association, on behalf of the International Federation of Pharmaceutical Manufacturers and Associations and our partners, the International Federation of the Red Cross and the Red Crescent Societies and the World Medical Association, I warmly welcome you to this event on the centenary of the 1918 influenza pandemic, commonly known as the Spanish flu. It is estimated that the Spanish flu killed more people in 24 weeks than AIDS killed in 24 years. In fact, the pandemic killed up to 100 million people, more people than all the wars of the 20th century combined. In 1918, this amounted to nearly 5% of the world's population. The Spanish flu serves as a poignant reminder of the importance of preparedness. If a highly contagious and lethal pathogen like the 1918 influenza were to take hold today, nearly 33 million people worldwide would die in just 6 months. More than ever, we are exposed to new biological threats, many of them yet undiscovered. In today's extremely interconnected world with people traveling at unprecedented rates, global health security has never been more fragile and never been more urgent. Previous epidemics have shown that when the global health community comes together, we are able to tackle infectious diseases. Going forward, we need to design and implement proactive preparedness approaches to further improve our capacity to prevent and/or quickly control unpredictable disease outbreak. Sample and data sharing are key. For influenza in particular, we recognize the importance of the WHO Global Influenza Surveillance and Response System and Pandemic Influenza Preparedness, the PIP framework, as well as the Global Initiative on Sharing All Influenza Data, GISAID. Through the PIP framework, influenza vaccine and antiviral manufacturers have helped the WHO to secure 405 million doses of influenza vaccine and 10 million doses of antivirals to be used in the event of an influenza pandemic. Although medical interventions such as vaccines are instrumental in helping us prepare against the pandemic, the 2014 Ebola epidemic and more recent one showed the personal tragedy associated with the lack of resilient, prepared health systems when faced with a completely unexpected threat. We have all learned powerful lessons, and we are encouraged by the swift international response to the current Ebola epidemic, including the deployment of a vaccine developed by MSD. So what do we need to do as a global society in order to ensure we are prepared as much as possible against global biological threats, against another pandemic such as the 1918 one? How to ensure that the world's global health security? There's obviously no one answer to this question, but before we start our panel today of experts, we have two remarkable keynote speakers among us who kindly made themselves available to share with us their thoughts on this very important topic. First, it is my great honor to introduce the Honorable Alex Azar, Secretary of US Health and Human Services. And if I'm not mistaken, HHS in terms of budget, and I think also in terms of importance for global health security, is the largest department in the US cabinet. Secretary Azar has spent his career working in senior healthcare leadership roles in both the public and the private sectors. His current tenure at HHS is a second tour of duty at the department. He served as HHS General Counsel from 2001 to 2005, then as Deputy Secretary, the department's #2 official and Chief Operating Officer. During his time as Deputy Secretary, Azar played key roles in international affairs, true interest in global health diplomacy, including public health emergency preparedness and response efforts and food and drug regulation. Secretary Azar, we are delighted to have your insights to open this discussion. Thank you.
Well, Tomas, thank you so much for that very kind introduction, and thank you to IFPMA, thank you to the International Federation of Red Cross and Red Crescent Societies, and to the World Medical Association for hosting today's very important event. This year we commemorate the 100th anniversary of the 1918 pandemic influenza, which was one of the, if not the deadliest event of the 20th century. The 1918 flu infected nearly 1/3 of the world's population, killing between 3 and 5% of the global population, upwards of 50 million people. With no vaccine to protect against influenza and no antibiotics to treat associated secondary bacterial infections, options then were limited. The world was ill prepared. As a result of the 1918 pandemic, many countries created or revamped their health ministries entirely, and there was increased recognition of the need to coordinate public health efforts at the international level. We now have more tools, including pharmaceutical interventions for prevention and treatment, national public health institutes capable of outbreak surveillance and response, and international coordination to mitigate pandemics. But influenza remains the top pandemic and health security threat to the world. As a global community, we are still woefully unprepared to combat major infectious disease epidemics. The ongoing Ebola, Lassa, MERS-CoV, cholera, and influenza outbreaks serve as stark reminders that infectious diseases are unrelenting and do not respect national borders. Today's interconnected world allows infectious diseases to spread faster than ever before, with devastating impacts to the health, security, and economies of affected countries. With some diseases, particularly influenza, we know that a major international epidemic or pandemic is not a question of if, but when. Yet we continue to be caught off guard by outbreaks that reveal deficiencies at almost all levels of our global defenses. Disease crises have destabilized governments through the erosion of public trust and confidence. Such crises pose threats to security, public order, and governance. They create economic havoc, undoing years of development gains. All countries must work together to prevent, detect, respond to, mitigate, and control disease outbreaks at all levels, from local to national. That is the most important way that we can minimize the destabilizing threat of international public health emergencies. We will accomplish this goal in part through a sustained, focused commitment to global health security. Such a commitment is vital to saving lives, efficiently using resources, and realizing the full potential of the international health regulations. The U.S. government supports the global health security agenda as a key mechanism to focus the world on building capacities to prevent, detect, and respond to human and animal infectious disease threats, whether natural, accidental, or deliberate. In our case, it is a whole-of-government effort, a prime example of coordination that leverages the numerous strengths from across U.S. departments and agencies. The success of the Joint External Evaluations, or JEEs, represents a significant accomplishment of the World Health Organization and its many partners around the world. More than 75 countries have already completed an evaluation over the last 2 years, and more than 25 countries are in the pipeline for one this year. JEEs have engaged ministries and sectors from across governments, outside of health ministries, reinforcing the importance of multi-sectoral action. They've also helped countries evaluate the status of their health security capacities and to identify priorities for future action. JEEs are only one step in the process, and they must be followed up by costed, multi-year national action plans that prioritize activities and identify the roles of the many multi-sectoral stakeholders involved. Countries must also identify resources to finance the work that's identified by their national action plans. We recognize that epidemic and pandemic preparedness cannot be achieved by individual governments alone. We must address sustainable financing for health security and encourage countries and organizations around the world to invest in supporting this much-needed work. We strongly believe that comprehensive global health security requires international partnerships across all sectors, including international organizations, non-government entities, and the private sector. Global health security will require diligence, focus, and commitment from all of us. The United States is a ready, eager, and committed partner in tackling this challenge and advancing the world's capacity to fight health threats. Thank you all for your attention, and we look forward to strengthening collaboration on these goals today.
Now, thank you very much, Secretary Azar, for this very convincing outline of the importance of global health security, and of course from IFPMA also the strong emphasis on the private sector's involvement. I would now like to give the floor to El-Haj Assi, Secretary General of the International Federation of Red Cross and Red Crescent Societies. El-Haj Assi has extensive experience in leadership roles in the humanitarian sectors, having previously served at senior level with UNICEF, with UNAIDS, the Global Fund to Fight AIDS, Tuberculosis and Malaria, and other agencies for more than 25 years. Before joining the IFRC, El-Haj Assi was UNICEF Director of Partnership and Resource Development in New York, and he has also served as UNICEF Regional Director for Eastern and Southern Africa and Global Emergency Coordinator for the Horn of Africa, which means he really knows about the importance of emergency preparedness. It is my pleasure to introduce to you the Secretary General of the International Federation of the Red Cross and Red Crescent Societies, El-Haj Assi.
Thank you very much, Thomas. So, dear Thomas, colleagues and friends, I would like, first of all, to thank my colleagues and friends from the U.S. government and Secretary Azar himself for being here with us today, the colleagues and friends of the International Federation of Pharmaceutical Manufacturers and Associations, and your very able and committed and practical leadership, Thomas. And my own colleagues from the International Federation of Red Cross and Red Crescent Societies, whose commitment on this subject matter is an unwavering one, and that for the last 150 years, since our creation. Yes, the world suffered the Spanish flu pandemic 100 years ago. But this year, last year, and then the year before last, we've been experiencing many alerts, that remind us how vigilant, we should be, and that pose the question, are we really ready for a pandemic of the scale and magnitude of the Spanish flu pandemic 100 years ago? This year, last year, and the year before, we had Zika. We had Lassa fever. We had Nile fever. We had Marburg fever. We had a yellow fever in DRC and Angola, which almost depleted the whole world's vaccine stockpile. And of course, we had Ebola, first time urban in 3 countries in West Africa, Sierra Leone, Guinea, and Liberia. An epidemic that at the time killed around 11,000 people. And when we got involved, to take on the work of safe and dignified burial, we were called 52,000 times to come and then care for the dead and then bury them. What are the causes of the surplus mortality of 40,000 during that time? All this, remind us again that we are not here, sitting and safe, waiting, for another pandemic to arrive, but we are seeing already signs, of many, that will beg the question, that we are asking ourselves, today. Are we ready? Are we prepared? Have we drawn, some of the lessons? And how can we together, build the required partnership, so that we avert another deadly one, of the scale and magnitude, that we know. all those outbreaks, that I mentioned, their location may sound extremely far away. So far as not only in Sierra Leone, not only in Freetown, but further down in a place that is called Kenema. Not only in Guinea, not only in Conakry, the capital, but all the way down to a small place that you can hardly identify on a map that may be called Gekedu. And today, when we have teams, working in DRC, they're not in Kinshasa. They're in many other places, the names, of which you may have never heard and you cannot even identify on a map. But all those outbreaks, no matter how far away they are, no matter how exotic, the names, of epicenter is, they're only one handshake away from many of us. They're only one plane ride away from many of us. It doesn't matter in which part of the globe that we are sitting. And those also reveals many of the dysfunctionalities that are underneath the public health challenges we face. We are not all equal in front of them. I have read that if you take some of the richest countries on the globe and then you look at the indigenous populations, you can find mortality rates that are up to 4 times higher than the surrounding populations when they face the same shock and hazard. So we realize again that there are so many other factors that people do not have control over that will be determining the level of vulnerabilities in face of these shocks and hazards in general, in the face of epidemics in particular. But again, none of us will be safe until all of us are. None of us, no matter how rich, no matter how far away, will be safe until all of us are, until we contain these epidemics and then those outbreaks exactly where they're happening, right there in the communities. It is always felt first at the level of an individual, at the level of a family, in a household, and then the community. And that is only then in those places where it can be contained. Of course, we all agree that we need international regulations. We all agree that we need to take preventive measures in every part of the globe. But we should make sure that also the necessary investments are being made where it is happening, at the epicenter of those outbreaks, because that's where we can contain it. If it is true, and I believe it is, that outbreaks and epidemics happen in the communities, I strongly believe that it's in the communities that we can contain them. And that's the reason why partnership is key. Partnership is key because dealing with these issues will reveal so many other problems that may not seem to be directly related to the challenge that we face. Cultural norms and values will come to the table. Fear will come. Stigma is on the board. Discrimination, exclusion, and all of that will be leading to some of the worst reaction that can be fueling those outbreaks and epidemics. And then we run a risk on maybe leaving those places at the times when we are needed most. Borders get closed, flights get canceled, trade is impacted, and all the other vulnerabilities that were there will be exacerbated. So that's why we believe that being there, and being there all the time, and I stress here all the time, in those communities and on the side of those needs to accompany them to respond will be critical. It will be very, very difficult to build a true long-lasting partnership in the middle of a crisis. So let's prepare. Before it hits, that's where we should be, so that we can engage in a trustful manner with those communities and then have the appropriate responses that are required. Communities are not only there as passive receivers of being a support, they should be also actors, very active members of the response. It is in the communities that one sees that something wrong is happening. People see that maybe they're losing more cattle this year than the year before. It is a sign of something. People know for a fact, from empiric observation that maybe they're going to more funerals this year, than the year before. They're seeing that there are more people falling sick and they're visiting in their homes. And these are all signs, of alerts, if they're taken and supported in a way that is better organized, provide a good base for community surveillance, that together, with the formal health system surveillance, will help us to recognize the early sign, the early alert that can lead to the early response. And then when we respond, and that is critical, that we always, build in those communities the capacity that will help them to withstand the shocks next time, the shocks come. Too many a times we go to the same communities responding to the same outbreaks and then coming back a year or two later, finding them exactly in the same level of vulnerabilities with the same challenges that we faced before. So the partnership there is key to have the community acceptance in terms of having the appropriate health-seeking behaviors, community acceptance in terms of vaccination, community acceptance, in terms of identification of cases and referral of those cases. Because driving people on the ground out of fear, resistance to vaccination because of all the misconceptions, and the myth, around it, can be some of the most important bottlenecks, that, we face in trying to respond. We don't need to wait 100 years or another 10 years until we get, to an outbreak at the scale and magnitude of the one, we have before, to realize, how urgent it is, to do what we need to do now. We need to start already, working in partnership, and I really welcome, our partnership, with the International Pharmaceutical Manufacturers Association. So in that regard, I appreciate very much the support we are getting from member states, such as the United States, in engaging in a longer-term partnership over years, so that we preserve the gains we make on the one hand, but on the other hand also explore new opportunities even to strengthen the partnership. We welcome and warmly welcome also the openness as well as the collaboration for WHO, so in that regard. Health system strengthening will be key. We all support it. It will not be sustainable without a community system strengthening. So we would like to make that contribution. We are present at the International Federation of Red Cross and Red Crescent Societies in 191 countries, in every place, where an outbreak may happen today, with over 12 million volunteers, on the ground. And we offer that first line of defense and that proximity and permanent presence, to partner with you to effectively prepare and respond, to an eventual pandemic. Thank you very much.
Now, thank you very much, Asif, for this extremely inspiring talk, which reminded me of our first conversation where in Geneva, where you are used to slogans and ideological warfare, I met the Secretary General who came and said, actually, I've had enough of slogans. We need to move from talk to action and should be down to earth. He also showed us that the issue of preparedness goes way beyond influenza preparedness. I would now like to hand over the floor to Claire Doul, former BBC correspondent and communication consultant and trainer, who will be facilitating this panel of experts who will discuss how prepared we are for the next pandemic, what are the lessons we have learned from the past, pandemics and epidemics, and what we can do as society in order to prepare the world for when, not if, the next pandemic strikes. Claire.
Thank you, Thomas. And I really do have a panel of experts, and I'm going to ask them to join me immediately. We have Dr. Ardis Hoven, who is the chairperson of the World Medical Association. Many of you will know it represents physicians worldwide, and you're an infectious disease specialist and former president of the American Medical Association. Welcome, Dr. Hoven.
Thank you.
Dr. Marie Mazur, who is Vice President for Pandemic Response Solutions for Securus, which is one of the leaders in the preparation of seasonal and pandemic vaccines. Welcome. Dr. Sylvie Briand from WHO, a woman who's very busy at the moment with the assembly going on. And she is part of the Health Emergency Programme. She's in the Pandemic and Epidemic Diseases Department, and she's Director of Infectious Hazard Management. Welcome. And last, but certainly not least, Dr. Julie Hall from the International Federation of the Red Cross and Red Crescent, who is Chief of Staff, but has had a long career at WHO and has been involved in teams dealing with SARS back in 2003 and coordinating response of H1N1 in 2009. So ladies, welcome.
Thank you.
So let's start with a quick fire round. This is the tweet round, and I should say to everybody that we do have a hashtag, which is hashtag global health security and hashtag health security. So let me begin with you, Ardis. Are we today better prepared? Are we today at all prepared for another pandemic on the scale of the Spanish flu?
The short and quick answer is no. I think clearly that, yes, we have learned and we have continued our engagement with our various partners around the world, but we have much yet to do. You know, I think about this very quickly. I will say that as we approach a pandemic of any kind, be it a current infectious disease or a re-emerging infectious disease, we can't be disease specific. We rather, in fact, have to be aware that we don't know what we don't know, so to say, and then bring it together after that. But no, we have much work to be done.
Sylvie.
I think we are better prepared, but still there is a lot to be done. And if I can summarize, I think any response to epidemic has 4 components. One is coordination. The second one is communication. You need health information and health interventions. And I think on those fronts we have made progress, but still there is a lot to be done.
Julie.
In 1918, it took 18 months for the virus to get to all the corners of the planet. Today, it would take 18 hours. We're certainly not prepared for that level of speed to be able to detect, contain, and control a large epidemic. The things that connect us, our travel and trade routes, help these viruses. The things that disconnect us, barriers, borders, poor information sharing, communities not being involved and engaged, all of those things that pull us apart, the viruses are very good at exploiting, and that we know. So again, the short answer, I think, is no. We're not as prepared as we need to be, and we're certainly not prepared for the speed that we need now.
Thank you. Marie.
We are definitely unprepared, not enough prepared, and this is a supply person who is talking to you about that. If you relate the numbers of 1918 to today's population, 7 billion people on the planet, about 200 million people would die right off the bat. So this is absolutely unacceptable. Now, if you take an economic response to your question, that would be like $7 trillion and a 12% GDP loss just by not being prepared. So no, we are not prepared.
Okay, so we're going to dig deeper. We're going to find out the lessons learned from some of those epidemic and pandemics that we're very familiar with, and to see what progress we're making. And Marie, I'm going to begin with you on vaccines, because there's a nice story here that Marie's parent company, CSL, was actually involved in the production of the vaccines which were used in the Spanish flu epidemic in 1918.
I just want to make a statement. I was not born. I just almost, but not there yet. I'm just looking at my numbers. Actually, CSL, which is an Australian headquartered company who are headquartered in Melbourne, has a very strong heritage in flu. We feel that when you get into flu, you have to be focused, and the company has been very, very focused over the last century. We just celebrated the 100th anniversary of the company and just getting started, but we have been in flu in every pandemic since 1918, in 57, and in 68, as well as in 2009. What's nice about the story about CSL is that during the 1918 pandemic, I want to correct Mr. Azar, we made flu vaccines. We actually inoculated eggs. We inoculated and we made 3 million doses. We have gone a long way because in 2009, we produced 220 million doses of pandemic vaccines. So yes, we have a long history and we believe we should continue to be focused on it.
Let's look at 2009 then, and what sort of lessons were learned from the industry on responding to that pandemic?
So definitely the upshot is that it was too late. We produced the vaccine far too late. The message that people have to understand is that the vaccine industry is part of a system. We work with WHO, we work with essential regulatory laboratories. We are just making the vaccine. We get information about the virus from WHO. When they give us thumbs up, not only the seed, but also there is an emergency and there will be a pandemic that's going to be declared. We go quickly into our labs and we work very actively. At the end of the process, we have to get the meaningful doses produced and released on the market. And again, we rely on another organizations, which is the ERL, Essential Regulatory Laboratories. They are telling us what you have in your vaccine is that dose. And there we can start distributing the vaccine. The whole process in 2009 was far too long.
Sylvie, would you agree you were involved in 2009? And I mean, what can be done to speed up the process or to get the countries with their pandemic preparedness plans to really see this as a priority?
Yeah, I think we tend to forget that vaccine is not vaccination. And so I think it's great to have a product, but we need to ensure that everything around this product and the system that will allow this product to be accessible are in place. And I think this is why partnerships are so important, because we need to make sure that everybody who is contribute to this difficult and complex process is involved. And again, I mean, those partnership and coordination mechanisms should be put in place before the crisis. Because when it's time to deploy millions of vaccines, which is not business as usual, of course, it's even more important to make sure that all these interfaces between different stakeholders are really smooth and will work well.
So we need to get the countries to actually make the contracts so that this can be speeded up, I would imagine.
Yeah, I think, so in this part we have some progress because recently we had an epidemic, H1N1 outbreak in Ghana, for instance, and the country was able to access the vaccine in 2 days. So I think it was a major progress compared to a few years ago, but this is only for one localized outbreak. I mean, if we have the entire world in fire, then it's another business, and I think this is to what we need to get prepared. So close relationship, working relationship before the crisis are really important.
And what can be done to make sure that there's really equitable access to these vaccines?
So I think this was an issue really before the 2009 pandemic, and especially with the avian flu, which started in 2003. And so member states of the WHO decided that we need to have a fair system in place for the next pandemic. So those discussions started in 2007, but unfortunately ended in 2011 with the adoption of the Pandemic Influenza Preparedness Framework. But what was really good, because the 2009 pandemic provided us really a kind of real-time simulation exercise, if I can say that way, that we saw really where was the bottleneck for first accessing the vaccine, deploying the vaccine, and for countries to use the vaccine. So since 2011, with the pandemic influenza preparedness framework, I think the global community has worked very hard, and it's a real partnership with industry, vaccine manufacturers, and antiviral manufacturers, but also civil society and member states to try to build up a system that will be really effective for the next pandemic. And as Thomas Kearney said, we have already secured 405 million of vaccine for next pandemic. It seems not much compared to the global population, but these vaccines will be obviously for the poorest country in the world, and we assume that the other countries who have really capacity to buy the vaccine will anticipate the pandemic and will be able also to secure the necessary amount of vaccine they will need.
So you've got deals from the pharmaceutical industry, from companies like Securus, to actually provide a percentage of their vaccine production for these countries.
Exactly. They committed to provide a percentage of their vaccine production in a timely manner. Meaning it's not that they will give us the vaccine at the end of the pandemic when everybody has been served, but really they commit to give vaccine. As they produce the vaccine, they will give a certain percentage to WHO. Plus, within the PIP framework, the Pandemic Influenza Preparedness Framework, industry is providing every year the partnership contribution. And from this partnership contribution, 30% is going to support the response in case of a pandemic. So we'll have money to ship the vaccine as well. And 70% is going to support the preparedness at country level. And currently, since the beginning of the implementation, already 72 countries have received this support. So we have made significant progress in preparedness in those countries.
And yes, I was going to say, please do
No,
respond.
I just wanted to highlight something because Sylvie is obviously focusing on the countries that WHO serves through the PIP framework. However, I would like to highlight, since we have probably representatives from the wealthy countries, that there is an issue about demand coming from the wealthy countries. The number of countries which have updated their pandemic preparedness plan is quite limited at the moment. I don't want to give names, but those names are public. Those countries recognize themselves. In the end, it's about capacity. It's about vaccine capacity. It's about what we call in our jargon pre-booking, pre-establishing contracts. And if those countries have not enacted, have not updated the plan, and have not enacted the plan by going out to meet with suppliers, they will not get the vaccine when the pandemic will hit.
So you don't want to mention...
Just to finish my point, when the pandemic hit, there will be no time for protracted negotiation. It will be too late. And we all have a role, even in wealthy countries, to protect the poorest countries in the world, because we're only one flight away. So we have a key role in these countries. And I hope that these meetings will open minds so that this can change.
No, I just wanted some details, of course, with the fact that you don't want to name names, but what percentage, percentage of countries do actually?
So, for instance, if I take the European region, it's known that only 16 countries have updated their plans, but some of them have not even implemented. We know that the joint procurement has just gone out in Europe. It took a lot of time to make it done. And hopefully, it will turn out that something will happen in those countries, but it's still not there.
Yeah.
And if there is a pandemic tomorrow, there won't be enough capacity because without orders, the suppliers, whoever they are, will not build additional capacity. They won't.
Yeah, certainly. Ardis, let me bring you in because it was mentioned in the keynote speeches too. Of course, there is skepticism about vaccines. And there's even skepticism about the flu vaccine and its efficacy, and even amongst healthcare workers. So what can you do to counter that?
Well, I wish I had a magic wand, but I don't. So let me back up a little bit. I think the challenge here, as we all know, that there is still reluctance to accept immunizations of any kind, in particular influenza. There are barriers as well, and there is information which is not scientific out there, which is driving some of this debate and disencouraging individuals from being immunized. What has to happen is we have to have systems in place which in fact accelerate the way folks can get immunized. not just those who have access to regular health care, but marginalized populations as well, and that's another discussion point for future reference. The other point that I would make is that when a physician says to their patient, I have been immunized, you should as well, it is much more likely to make sure that that patient will make themselves immunized and their family members as well. And then finally, the WMA, working with its various partners around the table here, have instituted an immunization community communication tool which has been in place for about 5 years now, teaching, educating, outreach, and instructing how to be sure immunizations get done, and immunizations specifically against influenza.
Yeah, sure. Let me just broaden it out. We've talked about influenza because, of course, it is such a difficult virus, and the Spanish flu connection. But let's talk about Ebola. It's in the news at the moment. I'm sure there's going to be questions about the efficacy of that vaccine that's being tested at the moment in the DRC. But it was the Ebola crisis, wasn't it, that really exposed the fault lines of the health systems and global health security. Sylvie, if I can just ask you, what were the lessons learnt? I know there were many, but concisely in terms of preparedness and response after that Ebola wake-up call.
No, I think Ebola was particularly difficult for the affected countries because there were countries with already, I would say, a weak health system and very thin health workforce. They had before the Ebola crisis about 1 doctor for 100,000 inhabitants. And unfortunately, 800 healthcare workers were affected during Ebola. So if you reduce the workforce for 800 people where it's already very thin, then you end up in a real big issue for your health system. And Ebola, it's not the only epidemic that really put health workers as first responders, but also at really high risk. Because even when you look at SARS or the MERS-CoV outbreak in Korea, for instance, we very often have healthcare workers affected. So I think what is very important, that's why vaccination is so important for them, because really it's an additional protection. Of course, we push a lot to make sure that they have the right personal protective equipment and that they can really provide care in a safe environment. But unfortunately, it's not always enough. And so we have really to increase the protection of health workers because health workforce is really what is critical for responding to an epidemic.
Ardis, I assume that you agree wholeheartedly with that.
200%. I mean, I think clearly that one of the challenges within our need for strengthening healthcare systems is first and foremost that we do address the workforce issue. If you don't have people to take care of people, it all falls apart. The other part of this that is extremely important is the surge capacity. So that, in fact, not only in countries like Congo and Angola and so forth, but in other parts of the world where we don't have the infrastructure in place to manage rapid onset of cases and what to do with them, both from a diagnostic standpoint in terms of surveillance, infection control practices, and that sort of thing. So we really need to spend time talking about surge.
And surveillance too, and let me bring Julie into the discussion because, of course, epidemics, they start and end with communities, and they're involved in surveillance too. Can you tell us, what were the lessons learned from Ebola for IFRC in terms of surveillance and engaging the communities and getting them not to, one, to be immunized, but also to make sure that all of these rumors and myths don't spread?
No, absolutely. I mean, an outbreak of any sort begins in a community, and it's the communities that are the eyes and ears of this. They can spot when things are unusual. So strengthening community surveillance is critical for being able to detect things quickly enough that we can then put all of these responses in place. But community surveillance is also critical because in being involved in it and learning more about infectious diseases, communities are much more then able to respond and put in place the very first measures. So vaccination is important, but it will take many weeks, many months before it becomes available. And there are many other things in our toolkit that can help us to control these outbreaks at the very beginning. And communities are absolutely essential to be able to do that. So investing in community surveillance so we get good early warning, investing in community education so that people actually understand about these things, and investing in community response is critical. But this needs to happen before an outbreak happens. You need to build the trust, you need to build the networks, you need to build the understanding in order for this to happen. The other thing is that many of these outbreaks either begin or certainly impact most heavily on the communities where there is very little, where the health systems are either fractured or non-existent. And the communities themselves are there to care for others. And so it is very important, obviously, to protect healthcare workers, but also all of those carers out in the community who are playing an absolutely critical role. So once again, investing in communities is vital across that entire spectrum of early detection, response, good treatment, and ensuring that we're able to control and contain as quickly as possible. 1 in 5 children are not vaccinated at this moment in time, and that is routine immunization. So whilst we have made progress when it comes to influenza vaccine, the capacity to quickly develop vaccines for unusual or emerging infectious diseases, we still have a fundamental problem at community level that some of those systems certainly don't exist, and that our healthcare systems are not able to either provide just routine immunization, let alone the massive surge that would be needed. So again, investment at community level and in basic healthcare is important right now for diseases that kill many, but it's also the foundation upon which you would build your surge, be able to do that vaccination, be able to respond properly.
Because Ardis, yes, I'm going to bring you in, but there was a wonderful fact I think that you told me, because of course the media during the Ebola crisis were concentrating on the Ebola victims, but in fact many more people died because of the collapse of the health systems and that they weren't strengthened.
That's correct. We know how many people died with Ebola itself, but then you've got the workforce and the community members that were involved as well because of the secondary effects that were occurring. And so that was those numbers reflect the cracks in the infrastructure that were not there to take care of these individuals. The other point I would make to your issue on community is the definition of not only the community at large, but the community wherein healthcare can be provided. For example, in more well-developed countries, you'll have, that point of care, that site of diagnosis, the first case of something walking through the door that should send up a red flag and say, I need to know more and understand. We've got to develop a culture of questioning and figuring out, where did this individual go and travel? Where did they come from? To whom have they been exposed? What animals have they been exposed to? And we've got to do a much better job within the healthcare community itself at that point of contact, developing that infrastructure, because we saw with Ebola that, at least in the country from which I come, there was great panic and fear and lack of some good information. So I think that's a very important element as well.
Yeah. And Julie, I mean, tell us, what is this chain of command when somebody does notice something unusual?
Yeah, I mean, as I said in the beginning, we're certainly not prepared for the speed. And if we're going to buy ourselves time, then absolutely, we need these early warning systems in place. It's around community spotting that there are unusual things or unusual die-off with the animals. But they need to be connected to the more formal system. So there's a way of developing those connections, but we also need to ensure that the trust is there as well. So working with the communities and the local health staff and the governments and the local governments to build not just the system, but the trust that if you alert something, then you will get help and you'll get support. And also, it's very much a no regrets. So you alert something, it's better to err on the side of caution, have a look, see what it is. If it's nothing, fine. But if it is something, then you will have bought absolutely critical time for us, because it will be a race against speed, because we live in such a connected world, and we need as much time as possible to be able to bring in all of the supplies and the support that's actually needed to contain and control this.
Sylvie, so there's community surveillance, really, really important, and you need the systems so that they can alert the healthcare professionals. What about the global surveillance system? I mean, how strong is that?
Yeah. And I think it's, for pandemics at least, it's critical, because pandemic is not a localized outbreak. It's really something that is spreading around the world, and viruses don't respect borders, as everybody knows. So, and this is where, I mean, the global coordination is really important, because we need to have standards for reporting information, collecting information. On flu, we are more prepared than on other diseases, because there is a global influenza surveillance and response system that is now 65 years old. And so it is composed of a large network of 153 laboratories around the world that are collecting on a routine basis all the viruses that are circulating, and exchanges those viruses to make not only to make to decide on the vaccine composition, but also to detect if there is anything unusual that is happening. And so those kind of global systems are really important, because they are the foundation of a global response as well. We cannot expect to all be coordinated for the intervention if we don't have all the same information. So I think those systems, it takes time to build, and that is where the collaboration of each country is so critical. We need to share information, and we need also to make sure that we analyze the information the same way, so that we can have a coordinated response as well.
Ardis, yes. How do you feel about the global surveillance system as it is, and this issue of exchange of data?
Well, I think clearly we're better than we were, but we still have a ways to go on this. And I think systems have to talk to each other. And as you've probably heard in my reflections here, I tend to think outside the influenza box. I think we must be in a better place in terms of other epidemic possibility, pandemic epidemics, in terms of new agents or re-emerging infections and so forth. So I think we've got to tee up that conversation as well. But let me take this down a little bit to a more community-based issue in public health. For example, in the country from which I come, from the United States, in some areas, it is extremely difficult for me to get healthcare workers to obtain the appropriate specimens to confirm a diagnosis, to feed the data onto the Centers for Disease Control, which feeds it on to the global centers. And so we must do a better job at the grassroots level of enhancing, obtaining information, data, and in order to help this surveillance work. It can't all be top down.
Do you have a solution?
The solution is, in fact, we keep talking about it, and we keep beating people. That's not the right word, but we keep
educating.
Education is very dramatic.
We continue to torment people with good information, and that depends on a healthy healthcare infrastructure and a very strong public health infrastructure as well.
I just wanted to comment on that there is a big progress which was done, I believe, by WHO with the IRAT system on pandemic flu, where you have this new tool which allows you to identify ahead of time strains of pandemic potential. And that's actually helping us a lot. Secretary Azar mentioned earlier the public-private partnership. Through the public-private partnership that companies have with the US government, we are leveraging this system, and maybe you can talk a little bit about it, in order to manufacture lots of pandemic vaccine candidate, that in the event of a pandemic being declared by WHO, hopefully, we would be able to right off the bat manufacturing in full speed surge capacity of pandemic vaccine. So I think that there are some coordination progresses which have been made that you should be proud about.
Thank you. I think it's a collective effort. I think what is very important is that indeed, during the 2009 pandemic, I remember that WHO was very criticized to be in bed with industry. And so, but I think WHO is not producing vaccines. So obviously, I mean, we need to work all together to make sure that health is protected. And so this is, we need communities, we need doctors, we need pharmaceutical companies. I mean, it's a beauty of partnership, but a challenge of partnership as well, because we all have maybe different views on the situation. So it's also a cultural mixture that we have to operate on, hopefully before the crisis, because when we are in a crisis mode, I mean, there is really not much time for in-depth communication. We have really to go to the action, and I think those kind of preparedness are really important. How to work across sector, how to work between private and public sector, how to work with communities and of national authorities. And all these different layers have to be harmonized, and instead of having a cacophony during the crisis, then we can have kind of a music that is nice to hear, but we are not yet there.
Julie, I was going to ask you, because you were coordinating the response to swine flu in 2009, so you've been on the front line. I mean, how do you better coordinate all of this goodwill between these different organizations?
Yes, I mean, I was helping to support that and the interagency coordination. And I think, as I said, the things that bring us together can help with the speed, but there are many things that separate us, and sharing of information, institutional barriers, borders, etc. These are things that we need to continually work on. So we've talked a lot about systems and technologies and tools that we have. But I think there are perhaps 3 mindset shifts that we still need in order to be fully prepared. One is that investment in preparedness is very cost effective. If you invest in preparedness, it can help in everyday activities around healthcare and help to strengthen that. And a penny spent on investment is worth X number of pounds in terms of saving yourself for response. But that mindset of investment in preparedness still isn't always there. That's number one. The second mindset shift is the no regrets policy. You know, if you see something and you're concerned, err on the side of caution. If you have, say, an earthquake, you see the damage in front of you, and often donors will support, everyone plows in because they can see the damage. When you have just a small number of cases, but of a disease that you think is serious and going to spread, it's often quite difficult to say to people, look, the projections are if we do nothing now, this is what's going to happen in a few months' time.
And that was your problem in 2009.
Exactly, and you need to actually put the effort in there and have a no regrets policy, being able to really sort that out. And then the third mindset really is around this continual need for sharing of information, and information sharing is a very early stage. So preparedness, no regrets, continual sharing of information, and building that trust in those systems.
Definitely. Sylvie, I just wanted to ask you something about, because of course we've talked about influenza, Ebola, Zika and so forth, but how do you monitor what the new potential diseases and pandemics could be? There was a very good article in The Economist, I don't know whether anybody read it, a month ago, which was all about the fact that you've now got a blueprint for potential diseases, and one's called Disease X. Yes.
Yeah, in fact, what we, so we have seen in the past 10 years or so, I mean, since the beginning of this century, many more emergence of viruses. Either it's really new, completely new viruses, or it's the re-emergence of old diseases that we thought we had controlled, but they are coming back. And so what is really critical is in this preparedness effort is indeed prepare the people that this may happen again, so they need to be ready for it, but also, if possible, have products in hand. And so it's impossible to prepare a vaccine or a treatment without knowing what will be the pathogens, but it's possible to prepare platforms for producing such vaccine or such treatment beforehand. And so what we try, and it's again, like Julie said, investing in preparedness, it's also investing in the unknown. Yeah. And it's not completely crazy to do this kind of thing, because those investments are definitively good investments. And so it's investing in research, because what the research that has been done, and you see it, for example, for HIV/AIDS, you know, when it started, there was no treatment, and now there are antivirals. But the research that has been done for HIV/AIDS has also served a lot of other diseases, because now we have also antivirals for flu, we have antivirals for hepatitis. So many things have happened thanks to this research. So it's very important to invest in something we don't know yet, but all the things that we can prepare in advance will be useful one day. Yeah. And so disease X is really just the name of any kind of disease. We don't know if it will be a respiratory pathogen, or Ebola-like pathogens, or Zika-like, or nobody knows exactly. But if everybody can get prepared to this unknown, I think we will make a significant step forward.
Ardis.
Yes, to that point, I think we also have to recognize that it's not just about research, but it is in fact what I call the mindset about being aware and willing to say that we don't know what it is, but in fact, what we have to do is be ready to be prepared for it. So it's the pathogen of unknown origin, or the pathogen that requires protection, that we need protection from. How do we do it? So how do we say, if you come across someone in a clinic setting or what have you, has an illness that doesn't quite fit, you should make assumptions that are not narrow, but those assumptions should be wide, and that you should begin the process of self-protection, employee protection, begin the investigation. Don't be afraid to ask the questions, to raise the concerns, and say, this may not be anything but, and be very broad in your approach to it.
Thank you. I think so. Before we go to the audience, I just want to, of course, you've seen that we've got no government representative on our panel, but I'm sure there are people from the missions in the audience. So, ladies, what role can governments play for better preparedness, and so that we are prepared if there should be another outbreak on the scale of the Spanish flu? Marie.
Okay. So from the supplier point of view, I think it's about enhancing the sustainability of the preparedness. We are in the business of preparedness. We have only one shareholder, public health, and we continue to invest on new technologies because there is no commercial market for a vaccine against Ebola. There is no commercial vaccine for a pandemic flu vaccine. The only customer that we are caring about are those folks in the governments who are going to procure and help us to sustain the surge capacity if it is needed, and to expand the volume of vaccine. So enhancing the sustainability of the enterprise, what we call the vaccine enterprise, is extremely critical. And this is what we are expecting governments to be doing with us. Julie. And we will be there, we will respond.
Yes. Julie, yes, mindsets.
Yes, all three of them. You know, invest in preparedness, and particularly at community level. That's an investment not just for the future, but for everyday events as well. Will strengthen health systems and the community link. The second, and this is probably the biggest message, you know, be willing to support a no regrets policy. Be willing to look at the projections, work with the experts, and make sure that we're able to respond quickly. Even if it wasn't actually needed, that was an extremely good investment, because the speed is something that we really have to be able to work with. And then third, obviously, the information sharing and the building trusts, whether they're between expert networks, whether they're between countries, or whether they're between officials and formal systems and community systems. Build the trust, build the information systems, share information, and be able to work more effectively, because the most important thing that we have, the only tool we really have to tackle viruses, is information and sharing it and working very quickly.
And governments, they need to improve their risk threshold. Yes, they need to become less risk adverse.
Well, I think so, especially around this no regrets. You know, we see something, like I say, it's very difficult. It's not like a big physical infrastructure damage that you can see in front of you. What you see is a small number of cases, perhaps in the beginning, but it seems unusual, it seems different. Invest very quickly in figuring out what it is and being able to support and share that information. It may turn out to be nothing, but if it turns out to be something, you've bought considerable amount of time by having that no regrets policy.
Sylvie, a member-driven organisation, of course, WHO.
Yeah, so as you know, our Director General has developed an ambitious GPW13 agenda, and one of the pillars is make 1 billion people safer. And even if it's 1 billion, and we are many more on Earth, I think it's not only for this 1 billion. I think it's everybody is concerned by this. So if we have key messages to give to member states, I think one of them is first involve your people, because a pandemic is a business of everybody. Everybody needs to know and be aware of it. Second message could be sustain preparedness. People tend to make big efforts when you have a big crisis like Ebola now. I'm sure that very many countries around DRC will start pushing for a number of assets, and this is good. I mean, they should do it and they will get prepared, but maybe when it's not anymore in the news, people will just say, okay, let's wait for the next emergency, but preparedness should be sustained. And the third thing, I think it's coordination, and not only within each country, cross-sectoral, but also ensure this global coordination, which requires a lot of effort, I think, because some people mentioned earlier the barriers to be connected, and I think health could be a good connectors, but also can disconnect people because of fear, because of panic. And I think to ensure this global coordination, we also need desperately the media on board. Everybody who can help for all of this should be on board, and this is very important. So this meeting also is quite important, I think.
Marie, you were looking at me.
Because you are the media.
Oh, no, I'm ex-media. I
just want to I'm completely in agreement with what Sylvie just said. I mean, the media play a key role. We spoke a little bit about vaccine hesitancy earlier, saying that the way the media are conveying the need for seasonal influenza as something that needs to happen every year in the world, this is going to go a long way in order to help strengthen and sustain the system.
Ardis.
All right. I think clearly that investing in our public health infrastructure, no matter where it is going to be key, and it goes to the issue of preparedness. Investing in our healthcare systems, those what we know are failing in certain areas, and being willing to say we do have a challenge here and what we must do. Partnering, allowing those healthcare professionals, be they physicians, nurses, whomever they are, and their national organizations and the national medical associations, to be looped in with government so that they are a part of the planning and the ongoing work that needs to be done in order to make this happen, not just when there's an emergency, but on an everyday basis and going forward. And last but not least, removing the barriers between agencies in order to communicate. I think we create these magnificent silos of information and knowledge, but how often do we share information with our veterinarian colleagues? How often are we doing the work in communicating? And I think that's a huge issue that has to be invested in from our governments.
Yeah, thank you. Now, I'd very much like to go to the audience. If you have a question, please say who you are and who you would like to answer the question. Yes, I see that there's a hand up at the back. Yes, please, thank you.
My name is Bram Palash. I'm a consultant on influenza and part of the IFPMA team. I think nature has given us a fantastic opportunity to test all those things we are doing on a yearly basis. Because seasonal influenza, the normal influenza, occurs every year, as we heard, and has the same challenges, although on a different scale, but has the same challenges as the pandemic. So I think that what we can do is build all these partnerships, make sure we better control seasonal influenza. That will give us a yearly exercise by nature. It will give us the opportunity to measure progress. Are we doing a better job from one year to the other year? And the more we improve our capabilities to protect patients against seasonal influenza vaccine.
And your question is?
My question is this an actual way of proceeding, trying in countries to use the control of seasonal influenza and build the infrastructure around it, as you have been discussing in the last hour, so that you use that as a model to improve the world for a pandemic.
Okay. Marie, and then perhaps Sylvie, who would ever like to have a go at that?
No, I completely concur with Bram's comments. It's absolutely critical. I tried to say that earlier. It's critical to strengthen the seasonal influenza marketplace for the very reason that it helps exercise, as you say, for when the pandemic hits. What we are fighting against is procrastination. And procrastination is very much related with the fact that the recommendations for seasonal influenza are disparate in the world. They are not the same. In the world, you have a universal flu recommendation in the US. You have at-risk population in most of the other countries. And in many countries, including developed countries, there is no policy for seasonal influenza vaccination. And that needs to happen. I think that maybe Gavi could play a role there. In order to elevate influenza really as an annual threat in those countries in such a way that funding would come and would enable these markets and these countries to have access to seasonal flu vaccine. I know that there are some talks in progress. I don't know if maybe Julie is aware of anything that she could share with us, but that would probably help a little bit if we could have that happening.
Okay, Julie, I don't know whether you do have something to share or whether you'd like to respond back to the question and then to Sylvie.
Yeah, I mean, yes, nothing specific to share, but I think it's not just seasonal influenza. We have many outbreaks that are occurring around the world, whether they be respiratory or they be vector-borne or food-borne. All of these are opportunities to learn and strengthen systems. And when I say we need a no regrets policy, it means that we don't sit there in a few years' time and regret the fact that we hadn't taken those opportunities to strengthen systems, to engage communities, to use it as something for all of us to learn through. So yes, seasonal influenza in those hemispheres that do have, seasonal big outbreaks does give us an opportunity to strengthen and to learn and to understand strains on health systems, etc. But there are plenty of other outbreaks that we need to be responding to effectively and learning from, and not sitting there saying, I really wish we had, and that's part of the no regrets.
Yes. Sylvie, yes.
Yes, of course. I mean, we need to use any opportunity to test the system, and also probably take into account the new technologies as well. I think with AI, we have the opportunity to build tools to simulate also big crises, and I think we should use this as a preparedness tool to simulate, especially, for example, because usually seasonal outbreak, it's something that you can control. It's not something so unusual, and hopefully it can improve over time. But what was really difficult during the pandemic is the size, the rapidity of spread. So there are some elements related to pandemic that are really difficult to test, and so maybe we can use a new technology, AI and so on, to test them also.
Yes, quickly I'll say, yes, we need to be using that. I think it gives us an opportunity to identify cracks in the system, get more people immunized. What are the barriers? What can we learn? What can we do to enhance the immunization numbers across our globe? I think that is key. And the other thing I think it allows us to do is improve our knowledge and understanding about avian influenza itself and high path and low path, so that in fact during these conversations we're building in a lot of new information so that we're updating ourselves all the time and testing our surveillance programs and testing our diagnostic programs in the process.
Thank you. The lady who's directly in my eye line, which always helps.
So there was a lot of discussion around the importance of vaccines, but thankfully since 1918 we've come a long way in terms of the tools we have and knowledge also. So can you talk a little bit about the importance of antivirals in pandemic preparedness and response, and what kind of guidance you're giving to governments as well? Thank you.
Thank you for your question. Yes, Sylvie, antivirals.
Yeah, I think we don't talk so much about antiviral because this is one of the things that worked quite well during the 2009 pandemic, because we used to have stockpiles and thanks to Roche that were a donation to WHO placed in different places in the world. So we were able to deploy millions of treatments in a matter of 3 weeks. So basically many countries were served. And also, many countries also had stockpile antiviral before the pandemic because, contrary to the vaccine, I mean, antivirals, unless we have a resistance, but otherwise we can already plan for this. So it's a tool that is very useful. And it has been mostly useful first to reduce severe mortality, the mortality in severe cases, and also to reduce the burden on health system. Because then people can be cured faster, so they can leave the hospital, so then you have more capacity, and you can help me, correct me if I am wrong, but then the health system has more capacity to take care of the sick. So.
Ditto.
Yeah, okay. Ditto. Okay, excellent. Now, I know that the pharmaceutical companies, there's not just Securus, there's Roche, and there's a gentleman from J&J. Who wants to make an intervention.
Thank you.
There you are.
How did you find me?
It's the sign on your head.
Right. I'm Alan Tenenberg, and I'm the Chief Medical Officer for Global Public Health at Johnson & Johnson. Thanks, first of all, for a very lively and informative panel discussion. Really learned a lot from the conversation. A couple of things that the panelists said. One, that we need to prepare or lay the foundation in order to have something ready for the surge. Another point that was made was that, the energy seems to ebb in between outbreaks. And a third was sometimes it's difficult to predict the next outbreak, what will be the next priority pathogen. CEPI, for example, is working on Nipah, Lassa, and MERS. Disease X, pathogen X, is certainly something that's on our mind, whatever it ultimately turns out to be. And the question that I have is it possible perhaps to solve all three of those problems by, rather than looking forward, but look backwards? We have around us infectious diseases that we have not been able to adequately address. Yeah. Tuberculosis remains one of the oldest but most relevant infectious disease killers on earth. Is it possible that by investing more time and energy in these diseases like tuberculosis or in antimicrobial resistance in general, that would give us the knowledge, the trained healthcare workers, the capacity and the capability to be ready for just about anything that comes out and attacks us in the future?
Mm-hmm. Yes.
No, absolutely. Couldn't agree more with your statement there. I think, you know, from a public health point of view, there's only a limited number of different ways in which an infectious disease can spread from one human to another or create an outbreak. We know what those are, and so by working particularly at community level, grassroots, primary healthcare level, on this is what you do in order to stop a respiratory disease spreading. This is what you do to help and control vector-borne diseases. All of these diseases, we've got plenty, sadly, of examples of them causing repeat outbreaks or repeat problems in communities in the world right now. And so I think you're absolutely right. Investing in getting those under control better, investing in communities actually understanding what they are and being able to help and support with all of that, and investing particularly in the grassroots primary healthcare, universal health coverage that we know would make a big difference, will help us develop a much stronger foundation for when disease X pops up. So absolutely, couldn't agree with you more.
Ardis.
Yes, I would agree. I think you said it more elegantly than I did when I was trying to explain how we needed to approach things, because it has to be much more global. It has to be much more non-disease specific, and we have to be very careful that we don't get very narrow visioned. But to the point you're making, and to the point you're making, We have got to invest in the social determinants of health. We cannot eradicate tuberculosis simply by throwing a lot of anti-tuberculous drugs out there. We've got to remove the conditions in which those situations are likely to occur. And so as part of this whole package is the investment by our governments in many of these social structures that are going to have to help us delineate what we have to do as well. So this branches us into a whole new space, but nonetheless, it's a space we need to be in.
Sylvie, yes.
Yeah, and I want to add that one of the characteristics of this century is also urbanization. And so I think we need also to revisit certain concepts like community, because we tend to think, oh, community is a small village. But what is a community nowadays in those big cities? We need also to revisit those social determinants of health, because maybe the poor or the vulnerable are not the one we think they are. And we need also to really adapt our tools, I think, to the modern and contemporary challenges.
Yeah.
Yes, thank you very much for that. There's most probably time for 2 more questions, and then I know that many people have to get back to the World Health Assembly. Yes, sir.
Thank you. I did learn a lot from you, and I have a question. That are there any mechanism in place that that to ensure the vaccine can be obtained during the pandemic by a country not a member of WHO? Because such as like Taiwan, we are not included in the vaccine supply mechanisms as currently devised.
Okay, you're from Taiwan, yes, indeed. I leave that one to Sylvie.
Yeah, I think for vaccine there is a market, so any country can access this market. I mean, WHO is not controlling the market at all. What WHO is trying to have through the pandemic influenza preparedness framework is making sure that the country in need, who cannot necessarily access it through the market, can have access to it through another mechanism, through donation from industry or tier pricing or any kind of mechanism that allow everybody to have access.
Taiwan is a market for you?
It is a market. We are working with Taiwan.
Okay, there's a lady at the back with her, I think it's a lady.
Yes, I am.
Even with my glasses on, I can be slightly blind. Yes, please tell us your name and your question.
Karolina Miljak from International Pharmaceutical Students Federation. And my question would be, how can pharmacists be involved in preparedness for the next outbreaks?
Excuse me, I didn't catch the first word.
How can pharmacists be prepared?
How can pharmacists? Thank you.
Thank you.
Ardis.
I will take that one. Pharmacists are part of the healthcare team. The healthcare team has to function as a team. And we have to collaborate with one another. We have to be real-time information sharing and be partnering and have planned ahead as to how I'm going to react and work with my pharmacists in my local community or in my state. So it's a partnership. It's a very important one, and we have to make sure that it exists before we find ourselves in a pandemic.
I'm very aware of time, and most probably that you need a bit of time to network and to go up the road to the World Health Organization. So I would encourage you, if you have questions, the speakers are here. We've seen how articulate and insightful they are, and I'm sure they'll give you very, very good answers. And I would just like Ardis from WMA, one of the co-sponsors of this event, to make some closing remarks.
Thank you very much. Today we have heard from experienced leaders on health security issues, on pandemic challenges. No, we are not 100% prepared, but we are making progress and we are better than we have been before. None of us, and I quote the Secretary General IFRC, none of us are safe until all of us are safe. I think that's a very important statement. We've learned about the importance of data sharing, preparedness, no regrets, where we stand with our vaccine supplies and the availability and challenges of getting individuals vaccinated. But I particularly want to send a thank you now to the IFPMA and the IFRC, and on behalf of the World Medical Association, thank all of you for being here today. I've enjoyed my panelists, my co-panelists, and I think we've had a very good discussion on a very important and timely issue. So thank you so very much.
Good job. Thank you. Where did you go?
Yeah. Can I have your contact details?
Yes.
We'll walk about it.
Thank you.
You know, it's not breaking news.
No, thank you very much indeed. Thanks. No, good to see you again.
I'll give you my card.
Thank you.
Yes.
Good.
See you around this week.